Good morning, everyone. It's 8 o'clock. We'll go ahead and get started. I'm Jessie Lewis, the clinic coordinator. Been out for a couple of weeks, so it's very nice to be back with you all. We have a pretty packed agenda today, so I'm going to go ahead and hand it off to Dr. Rao.
Thank you, Jessie, and welcome back. So we have a great presentation by Drs. Joseph and Perzynski this morning, and a couple of really interesting cases as well, which I'm looking forward to discussing. So just our structure of our clinics, we are going to try to get through the first part as soon as possible, especially since we have such a large group of experts here to discuss our cases. These are our disclosure statements. So Dr. Perzynski has a disclosure, as you'll note here, as do I. And you can read those at your convenience. Once again, a reminder about person-centered language recommendations. I am kind of consciously keeping track of how we're doing with this, and we are doing better week by week. So please keep some of these guidelines in mind as you discuss your cases in particular. And with that very quick introduction, Joshua, you want to take it away?
Perfect. Good morning, everyone. On behalf of myself and Adam Perzynski, we will be presenting today social, environmental, and cultural impacts upon body weight. The learning objectives are to explain how social and environmental context influences body weight, explain why specific subpopulations suffer disproportionately from obesity from a social, environmental, and cultural context, and describe stark neighborhood and regional differences in environments which influence body weight. And so earlier this year, we published a paper thinking about the cardiovascular impact of race and ethnicity in patients with diabetes and obesity. And really thinking through what are the individual factor levels, as well as the systemic, structural, and environmental factors. And so today we'll be kind of talking more about the systemic structure and environmental factors. Next slide. So many of you know, when we think about health in Ohio, that Ohio is 46th in health value and 43rd in population health. But important to today's conversation, the components that lead us to being 43rd in population health are really the things like physical activity, obesity, and premature death, all things that are really critical to today's conversation. These were the 2019 rankings. The 2021 rankings are very similar, except we moved to 47th in health value. So unfortunately not moving in the right direction. Some of the major causes of weight gain, as have been reviewed in this series previously, are increased caloric intake, decreased physical expenditure, allostatic load, stress, depression, psychiatric illness, poor sleep quality and length of sleep, as well as things like genetics. The FTO gene, you guys have seen that work, particularly in Mexican American population. Leptin deficiency, and some people discuss the two-hit hypothesis. There are also medical causes like hypothyroidism, Cushing's disease or syndrome, and Prader-Willi syndrome. Key to these are lifestyle modification, things like weight loss, weight optimization, physical activity, healthy diet. And we won't go into which diets are the best for weight loss, but a lot of data around the Mediterranean, the DASH diet, more data every year about the ketogenic diet, etc. When we think about weight gain and we think about the modifications that are needed to lose weight, they are impacted by our environment. If you are in an environment where that is easier, let's say you have fresh fruits and vegetables, for instance, that will be a much easier process. But all of us aren't in environments like that. And this really, kind of talks really is important in terms of the social determinants of health. So here you can see the downstream health outcomes, particularly obesity, particularly important for this conversation. These are influenced by midstream determinants, things like food insecurity and unsafe and overcrowded housing, unemployment, lower educational status. And these are influenced by upstream determinants, things like poverty, racism, and discrimination. And so we wrote a paper last year where we're looking at historical discrimination and racism during the slavery and post-Civil War era and how that impacts us even today. On the left, we have the medical and scientific contributors, things like eugenics theory, closure of medical schools after the Flexner Report, experimentation on vulnerable groups without their consent. All those things lead to decreased trust in the medical establishment, healthcare provider bias towards minority patients, and language and communication barriers. This leads in the healthcare context to poor access to care, decreased quality of care, decreased participatory decision-making, and decreased health literacy. There are also the structural pieces, the social conditions and policies, things like redlining and predatory lending that lead to residential racial segregation, inadequate investment to maintain public works and school systems, and discrimination in access to high quality jobs and adequate health insurance. all forms of structural and institutional racism. In the physical context, this leads to decreased neighborhood stability, cleanliness, sidewalks, open space, parks, decreased access to healthy food, and decreased affordable housing, all which increase stress, blood pressure, obesity, cholesterol, and blood glucose, as well as obesity and obesity-related disorders. I will pass it to my good colleague here and friend, Dr. Adam Perzynski, to take the next few slides.
Awesome, thank you. That was a great start. So I think, the way I like sometimes to distill what Dr. Joseph started off with today is really into this statement that sometimes the AHA's Life Simple 7 isn't so simple for lots of people. And that can be for all of these many layered reasons that Joshua presented in the conceptual model. And we look at these things: stop smoking, eat better, lose weight, control your cholesterol, get active, reduce your blood sugar, manage your blood pressure. They do seem simple, right? So in this project I worked on a few years ago, we talked to some Black men in Cleveland who had all had a stroke and were all between the age of 30 and 59. So they're like, these are young Black men who already had a stroke very early in life, about the things that made it hard for them to do these Life Simple 7 activities. Next slide, please, Jesse. And so this will be hard for you to read, but I just want to read a few highlights of the findings. So what we did was we mapped all of the risk factors for stroke and the health behaviors to fit to barriers that these guys told us about. And so I'll just read a couple of these. First, I focus on what's going on with African-American men. And one of the reasons why we were having so much stress, I think a lot of stuff is dealing with stress and social issues. When you start talking about it towards African-American men, the stress got to be at least 75 to 80% of why we even had a stroke. And so, a lot of these men talked about having stress all day long, high levels of stress the day that they had their stroke, difficulty managing and handling their stress, coming home from work and being stressed. And then they talked about other things like, well, one of my favorite ones in here is their reason for not taking their statin. This participant too said, sometimes I think of the doctors are just using us as a paycheck. If you get sick, who are you going to go see? Your doctor. Who gets paid? Your doctor. If they write a prescription for you, they get kickbacks. Now, I know that all the clinicians on here have no idea what somebody's getting at with kickbacks. You guys are not getting kickbacks when you prescribe a $2 statin. However, we have a deep history of mistrust and large flows of money in the healthcare system and huge differences in wealth between high income and low income communities. So these perceptions and beliefs are real and they influence people's behaviors. And so that it makes these behaviors not so simple. Next slide, please. And so, a lot of those day-to-day behaviors then sort of coalesce into creating these massive disparities that exist at the community level. So this is a figure from some ongoing work that I've been doing here in Northeast Ohio. This one uses data from the USA Life Expectancy Project at the neighborhood level. And what you can see is that the neighborhoods in Northeast Ohio with the highest and lowest life expectancy, and so the gap here is almost 25 years. Those two neighborhoods are the Woodhill neighborhood in Cleveland and a neighborhood in Shaker Heights that is only 1.2 miles away. You can walk 10 minutes and find a difference of 25 years of life expectancy. It is the most staggering disparity in life expectancy in the United States. Next slide, please. But the other thing is that these neighborhood factors have major influences on health. So in a neighborhood, you may have poor access to a supermarket. You may not be able to walk where you need to go. There are fewer recreational facilities, and traffic and crime and air pollution are there. Most of us have been through these neighborhoods, right? We see vacant houses, broken windows, dilapidated structures, And so like these are not areas that are conducive to healthy living in many cases. Next slide, please. So one of the really important things I wanted to highlight, and that, I think Dr. Joseph and I both agreed was important to highlight today, is that in Ohio, the differences in our neighborhoods are deeply linked to historical structures of racism and discrimination. And one of those historical structures is the practice of redlining. So in the 1930s and just before that, really sort of coming out of the Great Depression, the housing markets across the United States, particularly in cities and lending markets, were in very bad shape. And so the United States federal government, via multiple agencies, created maps of most US cities, including all urban areas of Ohio, where neighborhoods were determined to be suitable for lending along a scale from green to red. And red neighborhoods were determined as unsuitable for lending. So what that meant was that if an area on a residential security map was shaded red, no loan could be made there. And an example of this in Cleveland is that one of the banks in Cleveland was in a redlined area, and they wanted to build a new bank, but they couldn't get a loan from another bank to build a new bank because the bank was in a redlined area. And so what this led to is just a tremendous flight of capital from those neighborhoods that were redlined that we are still feeling today. So I did some work recently that's under review right now and is published in a couple of books, where what we did is we looked at the forms that were filled out when the raters in Ohio were actually making the decision about whether to redline neighborhoods. And we quantified all of the factors that they used: the cost of the homes, the lending environment, the condition of the homes, and the characteristics of the people in those neighborhoods. And what we found is that areas where any African-American lived were 40 times more likely, actually 45 times more likely to be redlined than other areas of the state of Ohio. Next slide, please. So to give you an idea of what that means, this is a very similar map of Northeast Ohio just from the 1930s. It's one of these residential security maps. And you can see a very, very tiny red dot in the bottom right quadrant there. And that is a neighborhood in Maple Heights. And this is what the rater wrote about his decision to redline that neighborhood in Maple Heights. And he says, about 2 years ago, a strong effort began to decrease the colored occupancy of this area and has resulted in the moving of 33 families. Only 50 are remaining, some of whom were moved at the city's expense. In each case, the removal of a colored family caused the occupancy of a white family in this neighborhood. There is also a tendency toward improvement in the physical appearance of the community during the same period. So here, what we have is documented by a US government official at a US government agency of the forcible removal of Black families from a neighborhood in a Cleveland suburb to make that neighborhood more white and more suitable. That neighborhood was still redlined though, because there were still 50 African-American families remaining in the neighborhood. So I think this is where, if I remember correctly, next slide, please. I'm going to hand it back from Cleveland to Columbus, because like I said, these maps existed for all of Ohio and all urban areas. And so I'm going to sort of like let Joshua take this thread back from sociology to in the 1930s to sort of present day weight management in 2022.
Yeah, just a couple more slides to finish up. Thank you, Adam, for that transition. This is the residential security map for Columbus, Ohio, where I am right now. And I'm actually sitting in a redlined area. Our clinic on the near east side of Columbus is in a redlined area in Columbus. And on the right side of this is present day vulnerability. And you can see the overlap between the areas that in 1936 were redlined and today have a high level of social determinants of health or vulnerability in these communities. Next slide. When we look at obesity, it's the same story. Once again, it's areas with high vulnerability, previously redlined, who have the highest rates of obesity in Central Ohio. Here on the left side, you can see the blue areas are areas where 1 in 2 individuals have a BMI greater than or equal to 30. And those are all in red line areas in Central Ohio. Next slide. When we look at these same areas, the area I'm sitting in right now, supermarket access is extremely limited. There is one supermarket, and if you're in the area where I am right now, it would take about 25 minutes to walk to it. There is no other supermarket in this area. There are corner stores, a couple bodegas, but no other kind of access to fresh and healthy foods. Next slide. And so, you know, it's really a stream of obesogenic environment, it's obesogenic behaviors, overweight, obesity, and then non-communicable diseases. So this is that same kind of upstream to downstream piece that we talked about earlier. Next slide. And when we think about the built environment and obesity, there have been a number of studies are done. I'm going to show you 3 that all show that food and physical activity environments where, you know, the major exposures were fast food exposure, urbanization, land use mix, and urban sprawl. And those were seen in this umbrella review published in 2021. Next slide. This paper looked at the associations between obesity, obesogenic environments, and structural racism and how they vary by county level racial composition. And they showed that racial inequality at the county level in poverty, unemployment, and home ownership were associated with higher obesity rates, while racial inequality in median income, college graduates, and unemployment were associated with fewer grocery stores and more fast food restaurants, both critically important in obesity. Next slide. In this last paper, looked at county level structural racism and did a very interesting analysis where they looked at ambulatory care ratios, primary care ratios, poverty ratios, white incarceration, black-white incarceration ratios, high school graduation rate, social dissimilarity index, and housing dissimilarity index, and found the major take-home point was that county level structural racism was associated with lower BMI in white populations and higher BMI in black populations. Next slide. And putting all of this together and kind of wrapping it around this concept of the social determinants of health, you all have seen the Kaiser Family Foundation and their 6 layers of social determinants. And this paper by one of my good friends down in Florida showed that, you know, when you look at quartile 4 compared to quartile 1 of the social determinants of health quartiles, there are higher rates of overweight, obesity, as well as class 3 obesity for, you know, individuals kind of living with the social determinants of health. Next slide. And taking it, you know, one step further, there are things like PM 2.5 and endocrine disrupting chemicals and their impact on obesity. And we know these things are higher in red line areas. I'm not going to show the studies on that, but we've seen that. We've known in Ohio, we have we're 48th out of 50 states for air quality, right? This is a major issue. And there are associations between PM 2.5 and obesity, as well as downstream to diabetes as well. And when we look at different endocrine disrupting chemicals, things like phthalates and bisphenols, everybody's water bottle, right? It's bisphenol A free, right? But they know, you know, we have study after study to show that these things are also associated with higher rates of obesity. Next slide. And so the last study we wanted to talk about was, you know, everything we showed you so far, much of it has been observational. This was an interventional study where individuals were moved from, you know, high poverty urban census tracts with greater than 40% of the residents having income below the federal poverty threshold and assigned to one of 3 groups. One received housing vouchers, which were only redeemable if they moved to a low poverty census tract. The second group received unrestricted traditional vouchers with no special counseling on moving. And the third group was a control group that received neither of these opportunities. This study is near and dear to my heart because my family actually ran 2 Section 8 agencies for many years. So I'm very familiar with these programs that they're talking about. Next slide. And what they found was that there was actually lower rates of BMI greater than or equal to 35 and BMI greater than or equal to 40 in the groups who were moved from a high poverty area to a low poverty area over the course of 10 to 12 years. They also showed, next, that there was improvements in glycolated hemoglobin in that study as well. And so when we're thinking about these impacts, it's not just observational studies. There are actually interventional studies that show a benefit to being in a better neighborhood, a better environment. And all that goes back to Adam's comments about stress and the multifaceted nature of how individuals experience stress and how that then leads to weight gain over time. Next slide. Thank you so much, and pass it back to Dr. Rao.
Thank you, Joshua, and fantastic presentation. We'll stop for a couple of questions. I just had a couple of comments. I think it's really alarming, enlightening, all the information you presented, and the question becomes, how do we tackle this problem? And my approach has always been to get people mad, to get people get mad about poor policing and housing. I want them to get mad about food too, but that's just my take on it. But here's a question for you that I've asked several people. What do you say to a bodega owner or convenience store owner in a poor neighborhood who says, well, I bought a whole bunch of fruits and vegetables, but nobody bought them and they all went bad, so I'm not going to do that again? Maybe Joshua, what would your response be?
Yeah, so great question. And there have been studies, for instance, out of Hopkins, where they've done that, right? There are many programs around the country to supply fruits and vegetables to bodegas and corner stores with varying degrees of success. And so, I think that the key piece here, Dr. Rao, is that these things don't exist in isolation, right? You can't do one piece, right? We talk about multi-level interventions being really important in addressing health equity. And so, like, for instance, here in Central Ohio right now, OSU Wexner Medical Center is building a healthy community center in that same redlined area that I talked about earlier. So that in addition to having a fresh market where people can get fruits and vegetables and produce on a weekly basis, we will also be we have a demonstration kitchen where individuals can learn about the power of cooking fruits and vegetables, right? Because if you drop fruits and vegetables into an area that has had no fruits and vegetables, doesn't know how to cook fruits and vegetables, it's going to, the effectiveness of it, as you're mentioning, is not going to be great, right? And so I think it's a multifaceted effort of figuring out how do you, one, deliver the things that are needed, but two, provide the education and support around it so there will be higher uptake of these critically important aspects for obesity.
Thanks, Joshua. Adam, any comments as well?
I think Joshua mostly covered it really well. The one thing that I would add is that it's also possible to advocate for within and between our healthcare institutions to advocate for and implement upstream changes. I think most of the academic large healthcare institutions in Ohio are sponsoring neighborhood improvement and redevelopment efforts. Metro Health is building a 12-acre park in the neighborhood where our hospital is, where 80% of people currently live at least 2 miles from a park. And so all of those people will have access to a new 12-acre park, like right across the street. And so I think like it really is possible to make these upstream changes in addition to the downstream tough, but it is tough, and it's very different. It's a different role for us in the healthcare system. And sometimes we have to slip out of our comfort zone and also be advocates.
Thank you, Adam. Okay, Rick, I think we should move on to our cases. Thanks for your great comments and presentation, guys.
Okay, thanks everyone. Really great discussion today. So just very quickly, you'll have your weekly post-clinic survey in your inbox already. Thank you for submitting those. We really do use the feedback, and we're already at 9 o'clock. So have a great rest of your week, and we'll see you next Thursday.
Thanks, everyone. Bye-bye.